Dr. Gundry, you have been a cardiothoracic surgeon. Okay, you've done thousands of operations, yet you have spent the last decade or two trying to promote healthy diets and healthy lifestyles. Now, right at the top, I'm very interested, as things stand today in 2023, do you believe that there is an optimum diet for humans to follow? And if so, what would that diet be?
Yeah, I think I just put my next book to bed actually this week. Turned in the manuscript, and I've been teaching people how to eat for 25 years now. And with each, I guess, passing year and with better and better testing, I think that there are certain things that people need to eat and certain things that people probably ought to avoid, but there's provisos. And I spent a lot of time looking at super old people in my practice. I've been blessed to learn from a lot of them. And I have spent actually a lot of research years looking at super old people around the world and trying to figure out what makes them tick. And so, for instance, my big blockbuster book was The Plant Paradox, which came out about 6 years ago. And since that time, I've learned a whole lot more than I knew back then. So every time I learn something new, I'm one of those idiots who say, hey, I probably wasn't right about this, and I've changed my mind. And here's why I've changed my mind. And so if people will allow me, I'll change my mind about things.
Now, I appreciate that. And I definitely want to talk about some of the things that you have changed your mind on or certainly evolved your view on. In terms of general principles, though, for people to follow, because here's the reality that I see, and I'm sure you're aware of as well, is that people are very confused these days about nutrition. And I've often thought that actually one of the problems is these days that we have nutrition experts, because what it used to be is that we would learn how to eat from our culture, from our parents, from our grandparents. We didn't need nutrition experts to teach us what we should be consuming. But somewhere along the line with modern living, with us moving, with the way we're now living, with the way jobs change, with the way pollution has changed, the way farming has changed, we've got to a situation where many of us feel sick a lot of the time, and we're looking for helpful information to get us feeling better. Now, the problem is that people hear different nutrition experts who they respect say some quite different things. And I really want this conversation to be practical and helpful for people. You have got a huge amount of experience. You've written many different books. So I guess what I'm trying to get to at the start is, are there some core principles that you think we can all agree on and are worth people trying to implement into their lives?
Yeah, I'll give you a famous saying from what we in the United States feel is the godfather of fitness. And his name was Jack LaLanne. And Jack LaLanne died in his late 90s. He actually died of pneumonia. He wouldn't take antibiotics, but that's an aside. And I knew Jack LaLanne in his later years. And Jack LaLanne used to have an expression that if it tastes good, spit it out. Now, a lot of my advisors say, would you stop saying that? Because you're scaring people that you want them to eat bark and twigs and bitter tasting stuff, and nobody will do that. And I said, well, no, that's actually not what Jack meant. And what he meant, and I think he was absolutely right, is that we actually should be eating for the 100 trillion living beings in our gut and in our mouth, the microbiome, instead of eating for this 2 by 3 inch piece of muscle in our mouth called the tongue. And if we eat for them, and give them what they need, we're their home. And they, in turn, will take care of us. And this is Hippocrates 2,500 years ago said all disease begins in the gut. And I spent the last 25 years trying to figure out how he knew that, because he was right. And another way of explaining that is death begins in the gut. And my research, lots of other people's research have led me to conclude that that's exactly right. If we eat not for ourselves, but for what our microbiome needs, the rest is a piece of cake. They'll take care of everything else.
It's really interesting in your latest book, not the one you just turned in, but your latest book, Unlocking the Keto Codes. A lot of the principles you outline in that book really are about supporting our gut microbiome, aren't they? And I found the concept in that book really, really interesting, tying this into the theme of what you are changing your mind on, what you are evolving your view on. It's really interesting in that book how you spoke about certain things you got wrong with the ketogenic diet. So I wonder if we could go into that. What did you previously think? And then when you did the research, what did you evolve your thinking to be?
Well, so I've had a ketogenic version of my diet really in all my books. And one of the things that kind of surprises people when they look at, quote, my ketogenic diet is there's a lot of bitter greens. There's actually a lot of carbohydrates in it. And there's a lot of polyphenol containing foods. And I didn't really have a whole lot of fat in the diet. I had specific fats in the diet that we can get into. And a lot of those specific fats in the diet were looking at the blue zones and what the blue zones ate and what made them blue zones. And I see people 6 days a week in my office, and I do blood work on my patients every 3 months. And the reason I started doing that is, well, I'd take certain foods away from people or give them certain foods, or I'd ask them to get a supplement at a health food store, or they'd take it away. And we could see patterns, and these patterns were actually pretty obvious. So in answer to your question, I would have a number of people do a traditional high-fat, low-carbohydrate ketogenic diet. And when they were doing that, yes, they would lose weight. And a lot of them felt a whole lot better. But when I actually looked at their blood work, at inflammatory markers, simple ones like HSCRP or fibrinogen or myeloperoxidase, and more complex ones like tumor necrosis factor alpha and IL-16 and IL-6, these people who were losing weight on this high-fat diet actually had inflammatory markers that looked quite impressive. And yes, a lot of them, their LDL, the so-called bad cholesterol, would go up. And I, quite frankly, could care less about LDL. We can get into that if you want. But they would oxidize their LDL. It would become rancid or rusty. And I come from the school that cholesterol isn't bad for you unless it's oxidized. So we'd see all these parameters that they'd be losing weight and they'd actually be feeling pretty good, but we'd see all these inflammatory markers climb. And so when I asked them to stop doing that, and they'd see it, on the reports, they go, whoa, then those inflammatory markers subsided. And so those are the sort of things that informed me that perhaps the traditional ketogenic diet is not a great idea.
Yeah, let's just pause here for a second, because I think there's a lot of terms now that are used in nutrition, like the ketogenic diet. And I think we could take 10 people doing a ketogenic diet and they may well be eating in very different ways. And I really feel when it comes to nutrition, we've got to be very careful how we talk about these things, right? So something I've started saying on this podcast quite a lot is that nutrition these days tends to be quite a divisive topic. And that's the understatement of the year. But I always say in the intros to my podcast that, look, guys, when you're listening to nutrition information, what information you need is going to depend on your current state of health, your goals, and your previous relationship with food. For example, if you are overweight and you have type 2 diabetes, the nutrition advice you need may be a little bit different from someone, let's say, who is underweight and who has been struggling with, let's say, an eating disorder, right? So I'm always quite conscious of that now when I put out information to say, look, who is this for? So if we go back to a ketogenic diet, for instance, as you've just mentioned, it's pretty well established, I think, that if you are overweight, if you have type 2 diabetes, that for some people, a form of low carbohydrate or ketogenic diet can be useful to help someone lose weight and stabilize their blood sugar, right? So that's the context. And you're saying that the way some people do that is ending up causing other problems. So in the short term, they feel good. And some of them, maybe not all of them, but some of them, and I've heard you say this previously, have got increased markers of inflammation, increased oxidized cholesterol, and increased blood vessel stiffness. I've heard you talk about these things. Really, really interesting. So by seeing that, what conclusions did you draw? What changes would you then ask those patients to make? And did you see those markers start to change?
Yeah. So, and again, I think this gets back to Jack LaLanne and Hippocrates, and I don't put them as equals, but anyhow, what happens, at least in this group of people, is the gut microbiome has evolved with us over millions of years, and the gut microbiome, for lack of a better word, enjoys starches, polysaccharides that normally, if we were eating a whole food diet, a lot of the undigestible starches that we can't digest would get to our colon, where the vast majority of our microbiome sits, and they love to ferment these undigestible sugars. And in that fermentation process, if we're lucky and we have the right diversity of microbiome, then they make some phenomenal compounds, which are classified as short-chain fatty acids, the most important of which is butyrate. And butyrate is probably the most important signaling molecule that we have available to us to make our brain work, to make our mitochondria work, to make us lose weight. You name it, make us feel better. You name it, butyrate is the key. When we do a very low carbohydrate diet, or even a FODMAP diet, where we remove all these fermentable sugars from our diet, we stop the process of making the short-chain fatty acids. And those short-chain fatty acids are, they educate our immune system, they keep the wall of our gut intact, they keep everything running. And that's what, and they make our blood vessels flexible. These are all generally classified as postbiotics. And so we'd see this on our patients. And then when we gave them back not only fermentable fibers, but also what I think is amazing to me, and I write about in the Unlocking the Keto Code, is you can't just give people fermentable fibers. Beautiful work out of Stanford by the Sonnenberg husband and wife team has shown that you can take two groups of human beings, give one group a lot of fiber, and the other group, same amount of fiber, but give them fermented foods. In this case, it was mostly yogurts, but ferment vinegars are fermented foods. Kimchi is fermented food. And look at what happens to their microbiome diversity and also their inflammatory markers. And what I think was shocking about this study, it was that the people who had got all the fiber didn't change their gut microbiome diversity. They didn't get more diverse, and their inflammatory markers didn't improve. But the addition of fermented foods to that fiber improved the microbiome diversity and made the inflammation go away. And you go, what? How's that happen? Well, the long and short of it is, all of us, all of our various cultures, wherever we originated in the world, all had a process of fermentation of various substances that we eat. And I mean, it's phenomenal when we look back at what cultures do, that cultures from recorded time detoxified plants with fermentation, preserved foods with fermentation. And I think this paper out of Stanford maybe starts to unlock, okay, what is it that all these cultures knew that, saved their lives, improved their lives? And that's kind of what I'm interested in.
Yeah, it's really interesting and goes back to what I was saying right at the start of this conversation, that we used to learn what to eat from our family, from our culture, and certainly not for everyone, but for a lot of us, that was all we needed to do when it came to nutrition, certainly in maybe a different era, maybe before this modern, hyper-industrialized world in which we live. So I guess it's going back as to what can we learn? What have we forgotten? What do we need to relearn? What you said there about fermented foods is really, really interesting, because so far, Dr. Gundry, what we've spoken about, what you've spoken about, is that we need to eat in ways that improves our gut health. Now, I mentioned also that nutrition has become very controversial, but most people, I think, would agree these days that eating to improve our gut health is a good thing. Professor Tim Spector in London would agree with that. The Sonnenbergs in America, as you just mentioned, they would agree with that. Okay, so I don't think so far that's that controversial. What you just said, that it isn't necessarily the fiber, but more the fermented foods that we should be focusing on. Now, that's very interesting because there's a bit of nuance there. So when you say fermented foods, what specific types of foods are you talking about? I think you mentioned yogurt and kimchi. Are there any others that we can think about bringing into our own diets?
Well, I think one of the most interesting things, and I've talked about this in past books, including the current one, is vinegars. And vinegars, it turns out that we do have, hopefully, what are called butyrate-producing bacteria. And there are certain bacteria that can take these starches and make this short-chain fatty acid butyrate out of them. But what's fascinating, particularly in researching my new book, is certain bacteria need the products of another bacteria to do their job. And in fact, it's so intertwined that there may be basically an assembly line of bacteria, and the poop of one bacteria is the food that a second bacteria needs to eat to produce a poop that the third bacteria needs to eat, and so on down the line until we get to the bacteria that can make butyrate out of all these other things, almost like a car assembly line. If the first guy falls down on his job, the guy ready to make butyrate doesn't have the things to work with. What's fascinating is, and I think this goes back to what the Sonnenbergs found, is a great number of butyrate producing bacteria actually have to have another short chain fatty acid acetate, acetic acid, vinegar, to actually make butyrate. And unless they have acetic acid, they can't manufacture butyrate no matter how much fiber you give them to work with. And I think that, to me, is really, again, interesting. Why is it that cultures fermented things? I'll give you another wonderful example that I think is a fascinating paper. It was published in February of this year, and it came out of the Netherlands. And you're probably aware of it, and it got a big splash that you take a bunch of people with stable angina. Now, stable angina is stable, and that people have blockages in their coronary arteries. And it's enough that if you're exercising fairly vigorously, you get chest pain or chest heaviness, angina. And if you stop, the chest heaviness goes away and you go about your business until you go too fast and the angina comes back. And it's actually a stable disease. That's what it means. It's stable. It really doesn't change. So what they wanted to do is they wanted to compare dairy usage in these people with stable angina and see if dairy impacted their stable angina. Did it become unstable? Did they develop a heart attack? And they had a beautiful little graph. And the paper said, gee, the more butter people eat, the more their stable angina becomes unstable, the higher the risk of a heart attack. And everybody nods their head and said, yeah, okay, butter, saturated fat, butter's bad for you. Okay, get it. Then the more dairy that people consumed, same sort of thing. Not as dramatic as butter, but more dairy, more chance of the stable angina becoming unstable. Interesting. That's what got the news. Dairy's bad for you. Now, down in the bottom of the paper, there was a kind of an aside that said, the funny thing is, the more cheese people ate, the less unstable angina they got. In other words, their angina actually got better. And it was statistically significant. And there's a beautiful graph that anyone can pull up on the paper, and you can just see it. The more cheese you eat, the better your angina gets. And you go, what the heck? Butter is really bad for you. Dairy's right behind it, but cheese? Well, it turns out that cheese is a fermented food. True cheese, not our processed cheese. And there are tons of important compounds in cheese that actually explains a lot of longevity in people who eat a lot of interesting cheeses that I allude to in Unlocking the Keto Code. So there's another interesting example that goes against conventional wisdom. And yet it's rather blatant when you look at really the studies of the impact of fermented milk products on health.
Yeah.
And it's not necessarily the milk product, but it's actually the fermentation process and the products of fermentation that are actually what makes things happen.
Yeah, absolutely fascinating. And I guess it really speaks to this idea that we have to be a bit more specific when we're talking about foods. Like dairy is a big umbrella term. What does it mean? Cow, sheep, goats. Are we talking about fermented, unfermented? And all of these things potentially in a certain individual will give us a different response. And so we have to be aware of that. I did find that section in Unlocking the Keto Code on dairy really, really interesting. I want to get to that because I think it's super fascinating when you pass that out. But let's just go back to this traditional ketogenic diet, as you call it. And as I say that, I'm aware that many people practice a ketogenic diet in a variety of different ways, right? So what we're saying is some people who choose to go down that path, maybe they've read it in a book, they've seen it on a podcast, their doctor is recommending them to do it. They are changing their diet and they're experiencing weight loss, more energy, and they're feeling really good. Now, I think that's step one. Step two, and I kind of feel that this is where we should all be going with our diets a little bit, is we need to experiment what works for us, use frameworks from experts, but then figure out what works for us. Now, the problem with that is potentially is if, like those individuals, those 3 patients you mentioned, if they are feeling great on this ketogenic diet that maybe has got a lot of fat in, maybe a lot of saturated fats, who knows what else, you're saying that some of those patients have got markers of increased inflammation, reduced blood vessel flexibility, and oxidized cholesterol. Right. So my first question with relation to that is, if someone's going to experiment with their own diet based on what they've heard so far, or your previous books or other people's books, what are those key blood markers do you think they should be checking, whether it's 3 months or 6 months or yearly, whatever it might be, to sort of give them the confidence that, yeah, I'm on the right line, said this diet, not only do I feel good, but my blood tests, my labs are also good. Have you got some key markers that you go to that give you a pretty high degree of confidence that actually, yes, this is working for this individual?
Yeah, I think, and they're becoming, I won't say mainstream yet, because I have 3rd-year family practice residents rotate through my clinic and for a month, and these are people who are about to go into practice. And so if there was one blood test to tell people how they're doing, predict their future, it would be a fasting insulin level. And fascinatingly, none of the 3rd-year family medicine residents have ever heard of measuring a fasting insulin level. And this is, at a good medical school in the United States. They know about hemoglobin A1C, which basically looks at the last 2 months of how you're handling sugars and proteins. But we see a number of people with a, quote, normal hemoglobin A1C who have very high insulin levels that are driving their hemoglobin A1C into a normal range, but they are tremendously metabolically inflexible. And they don't see it. It's kind of like the original Jaws movie. You could be swimming happily on the top of the water and there's a great white about to engulf you, and you would be oblivious to the fact that that great white was just underneath you. So a fasting insulin level is very useful. And even on a ketogenic diet, it's very useful.
And what kind of level would you want to see on that, ideally?
Personally, I'd like, at least on the American scale, 6 and under. Most people will say 9 and under is fine. The closer you get to 1, the better. My wife runs less than 1. I hate her. I can run at 2 or 3. Anyhow, but that's kind of the goal. But the vast majority of people with pre-diabetes, just yesterday, I saw a woman who has been told she's a pre-diabetic, and she's quite happy with that because she's not a diabetic. And yet, she has very high fasting insulin levels. She has measurable insulin resistance. And when I told her, well, calling you a pre-diabetic is like telling you're a little bit pregnant. And that got her attention because there's no such thing as being a little bit pregnant. And so she'd been going on for years with her well-meaning physicians saying, you're a pre-diabetic. She ran high triglycerides. She eats a very high starch diet, which was part of her culture. She's Middle Eastern, and that was their culture. And so in that context, she didn't really worry about, okay, my triglycerides are high, I'm a pre-diabetic. That's kind of me. But then when we dove in, she has lots of inflammation. In fact, she came to me because for the past 2 years, she's had chronic muscle aches. And people have chalked it up to statin drugs, and they've removed them, and her chronic muscle aches really didn't get any better. And I won't go into her any further, but just on your subject. So a fasting insulin level is, I think, incredibly important.
Yeah, that's really interesting. If I could just, again, on this, just pause for a second, because going back to this traditional ketogenic diet, so for people who are not aware, typically people will drastically cut down on carbohydrates, if not completely eliminate them, which stops raising blood sugar, which stops spiking insulin. This is a very simplistic take on this. I know a lot of people will be familiar with this, but for those who aren't, I just want to make sure that they're up to speed and can follow the conversation. Those people who were doing those ketogenic diets and feeling great, I'm guessing, had good fasting insulins. Or perhaps they didn't, because a lot of people who were doing that, yes, they had markers of inflammation, they had other markers which you didn't like. But on that one marker, fasting insulin, I'm guessing that was okay for them, right?
Yes, indeed.
So fasting insulin is a helpful marker, but it's not sufficient in and of itself, because those cases you're talking about, which in some ways prompted you to write Unlocking the Keto Codes, those guys had a normal fasting insulin or an optimal one, yet they had some other problematic markers. So beyond fasting insulin, what are some of those other markers that you think are really important for people to look at?
So let me give you an example of a paper that actually just came out yesterday. It took 18 individuals who were going to practice a traditional high-fat, low-carbohydrate ketogenic diet. And the purpose of the paper was to look at lipids. And they wrote that their baseline LDL was about 127. Don't quote me, but about 127. Little high for most people. I could care less, but a little high for most people. These 18 individuals, when they went on the ketogenic diet, most of them, which actually surprised me, more than doubled their LDL. Some people went to LDLs of, I kid you not, at least in this paper, 500 and 600.
Oh, wow.
And these physicians who were following them, they did the ketogenic diet for a year. And some of these people, the researchers convinced them, if they were going to continue on this, because it was a year study, please start taking a statin drug because we're scared to death. Interestingly enough, during this study period, nobody had a cardiovascular event. Then, when they stopped the study, their LDLs came back down. And the purpose of the study was, wow, be careful. A ketogenic diet is really raising your risk factors for heart disease. Now, the problem with that study, and that gets to part two, is they did not look at either inflammatory markers, but more specifically, they did not look for either oxidized LDL. They did not look for a better test, which is called ox-phospholipid ApoB, ox-PL-ApoB, which even takes into account another particle called LP(a), oxidation. Yeah. They didn't look at any of that, nor did they look at markers of stickiness of blood vessels like LP(PLA2), the plaque test. They didn't do any of that. And so all they were looking at was an LDL going up. And they'd even look at ApoB going up. But the point was, and I see this in my practice all the time, I have people who run LDLs of 400, and yet they don't have oxidized LDL. They don't have OXPL ApoB. They have absolutely no stickiness of their blood vessels. And when under duress, we do a CT coronary angiogram on them, they have absolutely no plaque in their blood vessels. None. Now, is that everybody? No. But the idea of just studying LDL from a ketogenic diet and saying, oh my gosh, the LDL went through the roof, doesn't tell me anything, quite frankly.
Yeah. There's a couple of things there. Very interesting. Thank you for sharing that. I've not seen that, and it only came out yesterday. So I will, after this conversation, I'll go and try and dig it out. But the first thing you mentioned, that one of the conclusions you mentioned that the researchers made was that the ketogenic diet is increasing your risk of a cardiovascular event, or words to that effect. Now, again, to be more subtle and nuanced, we can't, let's say that there was an increased risk. We can't say it was a ketogenic diet. We can simply say the way that they were doing their ketogenic diets. Again, I'm really keen that this conversation is helpful for people. And I know there are multiple ways of doing a ketogenic diet. Information is not enough to make change in your life. You have to take action. So to help you take action after watching this video, I've created a free nutrition guide for you. This contains the 5 most important practices I've seen in over 2 decades of seeing patients. They work for you no matter what your dietary preference. There's a step-by-step action plan to help you implement those changes in your life. If you want to receive that free guide right now, just click on the link in the description box below, which I think that nuance is not often brought in. So that's the first thing. The second thing, I guess, is this thing about LDL then, you know, we're going into some very controversial territory, right? Because there is a school of thought now which is saying that LDL should be as low as possible for as long as possible, right? So this is a cumulative risk that builds up throughout your life. So whatever the level is, you want it lower. And actually, I spoke to Peter Attia recently on my podcast. Yeah. And I actually said to Peter, I said, look, some people who follow whole food-based, low carbohydrate diets and are feeling better, sometimes their LDL level will go up. And there is a school of thought within that community that will say, if your inflammation is down, if your triglycerides are down, which of course it generally will be on a low carbohydrate diet, if all these other markers are down, is that LDL a concern, right? And Peter's view was very much, well, why choose? Sure, have inflammation down, have a low fasting insulin, but also bring your LDL down as low as you can. That was very much his view. You are a very well-respected cardiothoracic surgeon. You have done heart operations. You have seen blood vessels, right? You've seen diseased blood vessels. How would you pass that out? What would your perspective be on that in relation to LDL? You've said several times in this conversation, LDL, you're not that bothered about that, but oxidized LDL you are. First of all, maybe explain the difference between those two things, and then how you would ask someone to proceed if their LDL is starting to go up.
Yeah, I have a great deal of respect for Peter. I've spoken with him on actually mutual patient management. He is old school trained, particularly from the East Coast of the United States. I'm West Coast trained in lipids, and quite frankly, the West Coast and the East Coast of the United States do not see eye to eye and agree on lipid management. But let me put on my cardiothoracic surgeon hat. Michael DeBakey, Denton Cooley's mentor, one of the fathers of heart surgery, always used to say back in the 50s that cholesterol has nothing to do with heart disease. Cholesterol is merely an innocent bystander. that gets trapped up in inflammation that occurs on blood vessels and is basically a spackling compound that patches cracks and potholes. And the more cracks and potholes that occur, the more cholesterol will patch it, and that can lead to a bigger patch. I use the example in the book. Let's suppose I am an alien who has been sent down to orbit Earth and to report back to high command things I observe on Earth. And one of the things that I could report back is that I'm pretty sure ambulances cause car accidents, because every time I see a car accident, there's an ambulance. And, association does not mean causation, but that would be a potentially valid observation. And I think DeBakey was trying to say that, is that, yes, we do see cholesterol in plaques, but the cholesterol did not cause the plaque. The cholesterol was there patching inflammation. Now, that gets back to where I think Peter and I probably disagree. For years, the cholesterol hypothesis was propagated because statin drugs clearly lowered LDL cholesterol. And it appeared that the lower our LDL went, the less plaque and probably the less cardiovascular events we saw. And so we made the association that it was the lowering of LDL that was actually what was causing the process. Well, then fast forward for a few years, and we now know that statin drugs work by blocking toll-like receptors on blood vessels. And toll-like receptors, and I write about in my books, I call them TLRs, tiny little radars, are what sends out the signal in terms of inflammatory cytokines to call the immune system into action. And so what was actually happening, I think, with statin drugs is that you were suppressing the inflammatory signal. You were suppressing inflammation. And the more you gave of this, the more you would suppress inflammation. But the more you gave of it, the lower your LDL would go down. And so, again, association is not causation. Mm-hmm. And so if there is no inflammation on a blood vessel, then there's absolutely no reason for that ambulance cholesterol to show up.
Yeah.
And so that's number one. I've gotten more and more and more interested in the processes that guard our blood vessels. Just like we have a mucus layer that lines our gut, which is incredibly important in lots of ways, and we can go into that if you want. We have a similar mucus layer that lines our blood vessels called the glycocalyx. Mm-hmm. We also have a similar mucus layer that forms our blood-brain barrier. We also have a similar mucus-like layer that supports our joint surfaces. And it turns out these mucus layers are fascinatingly made out of certain sugar molecules, glycans. And I think that heart disease, brain disease, joint disease, all comes from a breakdown or attack on these various sugar layers. On the West Coast, Berkeley, the University of California, Berkeley, years ago developed a system of looking at the various sizes of LDL particles. And there's basically 7 of them, big ones and little ones. And it became fairly obvious that the little ones were the troublemakers, and the big ones actually didn't seem to be of any trouble at all. I used to tell my patients that the big ones were beach balls that bounced along, and the little ones were lead sinker weights. If you went fishing, you put on your line. And as long as we were making big ones, we were fine. And as long as we weren't making too many of the little ones, we were fine. And that was kind of the West Coast theory of heart disease. Recently, because of these advents of measuring oxidized LDL, or I think oxidized phospholipid ApoB, we can further differentiate those individuals who have sticky cholesterol, for lack of a better word, and those people who have Teflon-lined cholesterol balls. And to me, that's, opened up, I guess, my eyes as to, okay, who do I really need to be worried about?
Yeah.
Now, don't get me wrong. I use statin drugs. If I break, and I use the example, if I break my leg skiing, I'm going to wear a cast. And I'm going to wear the cast till my bone heals. And then I'm going to take the cast off. I view statin drugs as, okay, I have an inflammatory event that has, started this. I've just put a stent in somebody, or in the past just did a bypass. I want to block as much inflammation as I can until I can correct the factors that started that inflammation in the first place. So I'll use a statin drug, but it's not like once I correct the problem, to me, there's no good reason to continue a statin drug.
Yeah. I really appreciate you going through that, Dr. Gundry. As I said before, improving our gut health is something that there's general consensus on, I would say, by most people these days. But what we do about rising LDL levels in the face of improving health from every other metric or many other metrics does seem to be one of these quite hot topics at the moment. Very, very controversial. I appreciate you putting forward your perspective on that. I think certainly as a MD who's practiced in the UK for all of his career, I think one of the problems is that we just don't have access to a lot of these tests.
Right.
In the National Health Service, even still to this day in 2023, you can't get a high sensitivity CRP. You can just get a normal CRP, right? For lipids, you are just getting total cholesterol, LDL, HDL, triglycerides.
Yes.
So without the nuanced testing that you are doing with your patients, and also Peter is doing in his clinic with his patients, where you're getting these sensitive markers, I think it's quite hard for clinicians to feel confident in the face of what they've been taught. And me personally, in my mid-40s, once a year, I pay privately for these advanced cardiac tests because I want to know what's going on. Yes, I have an NHS doctor, but I also know, well, it's not on offer. I want to check my LP-little-a. I want to check my ApoB. I want to check myeloperoxidase. I want to see all of these things to make a balanced view on myself. And of course, I hope that that's more mainstream and more widespread in the near future. So I think this is one area which we'll have to park and say a little bit controversial, but I really also appreciate your very clear perspective on that. And I also would say that, of course, any intervention has pros and has potential downsides. So yes, while statins may be indicated for some people in certain situations, a fair degree of people struggle to tolerate them. They have cognitive dysfunction afterwards. We know that they can negatively affect our mitochondria. And I want to get to mitochondria shortly because you've written a lot about that in multiple books of yours. So I think everything needs to be weighed up. And I think this general point that we're sort of highlighting throughout our conversation is we can't really just take one thing in isolation. We have to look at the whole picture of the patient. What else is going on? What are the other markers telling us? So yeah, let's just park that for the moment, unless you have anything to come back on from what I've just said.
Yeah, actually I do. Long before we had these tests, one of the things I would really follow is the triglyceride to HDL ratio, not HDL to LDL, not triglycerides to HDL. Triglycerides, as a general rule, are the first form of fat that we manufacture from sugars and starches. And triglycerides, when I'm managing things, what I want in an ideal world is HDL, the so-called good cholesterol, to be higher than triglycerides. Women are pretty good about doing this. Men struggle more. But triglycerides, at the very least, the closer I can get triglycerides to HDL, the better. I'll give you a personal example. When I started on myself 27 years ago, I had an LDL of about 166. I had an HDL of 32. Horrible. And I had triglycerides of about 160. In the United States, 150 is considered the upper limit of normal. And I was told by my colleagues that, well, you're screwed. You inherited this from your father, and there's not much you can do about it. And, go take a statin. Well, when I met Big Ed, the guy who changed my life, I altered my diet. And within 3 months of altering my diet, my triglycerides went from 160 to 40.
Wow.
And my HDL of 32 went to 80. And my LDL went to about, 80, as I recall. So I had the same genes I had when my cholesterol profile was wildly out of whack. But I just told my genome that basically it was the middle of winter by the way I was eating and to shift these things around. We have some fun games that we play. If the lowest I've ever gotten my triglycerides was 30. My wife's done a 22 just to piss me off. And we have little games that if anybody can get below 40 in my clinic, they get a little gold star, literally a gold star. And they put it on their forehead and walk out. And as triglycerides go down, HDL goes up. And as triglycerides go up, HDL goes down. And you can watch it every time. I actually have never seen it not happen. Now, the one exception, when we have people on a profound weight loss, ketogenic diet for the treatment of cancer, some of these people will have very high triglycerides, fasting triglycerides. And I thought they were cheating until I realized that what these people were doing is they were extracting so many free fatty acids out of their fat cells and using free fatty acids and ketones as their only available fuel, that the triglycerides I was measuring were these transport molecules carrying all these free fatty acids around. So that's the exception to the rule. In general, and Tim Spector has talked about this personally. He manufactures a lot of triglycerides when he eats starches, and his wife can eat the same amount of starches, have 3 croissants for breakfast, and she doesn't make those triglycerides. Yeah. So you're right. There is individuality in all of this.
Yeah, and I think that's where we're moving to in nutrition, isn't it? General principles, but then we have to personalize. We have to test probably to check, is this working for me? Do I feel better? Have I got more energy? Have I got more vitality? But also, are my blood markers going in the right direction as well? I definitely want to, at some point in this conversation, talk about lectins. I want to talk about mitochondria. But I think there's a wider question here, which is, what on earth is a cardiothoracic surgeon doing talking in depth about nutrition? You mentioned Big Ed, of course, this patient who I think in many ways changed the trajectory of your career. So I wonder if you could outline those, but also outline what dietary changes did you make, Dr. Gundry, to have such a profound change in your lipid profile?
Well, and I won't, as an undergraduate at Yale back in the dark ages, we were allowed to design our own major, a course of study for 4 years where, if we were lucky, we just worked with a bunch of full professors. And I was chosen to do this. It was basically like doing a master's in college. And you had to have a thesis, and your 4 years of study was to defend your thesis, write a thesis. And my thesis was that you could take a great ape, manipulate its food supply and manipulate its environment, and prove that you would arrive at a human being. That was my thesis. And I defended my thesis and actually got an honors and gave it to my parents, and went away and became a very famous heart surgeon and never kind of thought about it again. So when I met this gentleman who I call Big Ed, who dramatically reversed inoperable coronary artery disease, inoperable blockages in his coronary arteries in 6 months' time by changing his diet and going to a health food store and taking a bunch of supplements. When I asked him to describe the diet that he had adapted, I stopped him a few sentences in and said, wait a minute, that's my thesis in college. And, wow. And when I asked to see all the supplements he was taking, I am very famous for protecting hearts from dying during heart transplant and during heart surgery. And I had a concoction that I would put down the veins and arteries of hearts to protect these hearts, the cells. And a lot of the stuff that I was putting in my cocktail to protect the heart from dying, he was swallowing. And, never occurred to me to swallow them. So long story short, my parents sent me my thesis, and I was a big fat guy. I weighed 228 pounds, even though I was running 30 miles a week, going to the gym 1 hour every day. I was a very large version of Peter Attia. I was a Clydesdale runner. And I was eating a very healthy, low-fat diet because I was professor at Loma Linda University, a blue zone. And that, of course, is healthy for you. So I basically got rid of my low-fat, healthy high carbohydrate diet and began to eat as if, long story short, it was winter, and I began to eat a large amount of leaves, and I stopped eating fruit, and I started taking a bunch of supplements that I got from Costco or Trader Joe's or health food stores. And I lost 50 pounds my first year. My lipids flipped in 3 months. And I lost subsequently another 20 pounds, and I've kept it off now for 25 years. When I started doing this with my patients who I operated on, we started to see the same things. People's diabetes would reverse. People's arthritis would reverse. People's blood pressure, would plummet. They call and say, hey, what kind of supplement are you giving me that my blood pressure is going down? And I'm going, there's no supplement that does this. Come on here, let's check. And sure enough, their blood pressure was a lot lower. And we go, well, let's back off on, this drug. This went on for about a year at Loma Linda. And I had really an epiphany one morning that I was going into work, and I said, I got this all wrong. Instead of operating on people and then teaching them how to eat so they'll avoid me in the future, because quite honestly, I was very famous for reoperations. Every 5-7 years, you'd redo what you did. Mm-hmm. And that I thought there must be a better way. So I resigned my position. Wow. I said, I need to teach people how to eat, and then I'll never have to operate on them again. And that's really stupid for a heart surgeon, as my wife reminded me year after year. You can't make much money teaching people how to eat. But because I am and was a researcher, when I set up my clinic, I just said, hey, I want to ask you to take away certain foods. I want you to add certain foods. I want you to go to a health food store, buy some supplements. I want to measure blood work on you every 3 months. And if you want to play, you're my research project, and you'll learn something, I'll learn something. And that's how it all started.
Well, thank you for sharing that. It is a really, it's very invigorating to hear that you were very successful. You were in the prime of your career. You were doing certain things, and then a patient, an empowered patient. And I've heard you tell that story before, and I believe that actually you didn't advise him to make these changes. He made these changes off his own accord and persuaded you to rescan him and redo tests where you saw the reversed coronary artery disease, which is really quite profound because it's still not conventional wisdom that we can reverse established atherosclerotic cardiac disease. Whereas you and the other doctors as well are talking about this through changes in our lifestyle. You mentioned yourself, you ate as if it was winter. You cut out all fruit. You put more greens into your diet. But what else did you do? I mean, what about meat, fish, protein, these sort of things? Because people will want to know, okay, Dr. Gundry, that sounds incredible. What did you do back then? Or I guess the more pertinent question is, Dr. Gundry, how long ago was that? And although it was successful, what you did, if you were doing it now, would you make any modifications to the diet that you chose back then?
Yes. And that's, again, maybe when we started our conversation, thankfully, because of my patients, I'm able to see, okay, this tweak works, this tweak doesn't work, or it doesn't have much of an effect. And one of the chapters in the new book is called The Plant Paradox 2.0. So it's kind of, all right, what have I learned from, the Bible since it came out? And so one of the things, maybe we'll dive into that part. Loma Linda is a Seventh-day Adventist institution, and Seventh-day Adventists, as a general rule, are vegetarians, and a lot of them are vegans. Those who do eat animals certainly use dairy products and eggs. A lot of them eat fish and chicken if they're going to. So I grew up in Omaha, Nebraska, and Nebraska is called the beef state for a reason, because of its very heavily beef-eating, beef-producing area of the United States. So I have no dog in the fight of is animal protein good or bad for you, but one of the things that I've, I guess, learned, and so I made my changes when I was 45 years old. I'll turn 73 in a month. And, so far so good. And it's one of the things that I've seen from my patients, that I've seen certainly from myself, is there's a fascinating two problems. Number one, whole grain goodness, as we call it in the United States. The reintroduction of whole grains into our diet has really only come in the last 60, 50 years. Before, a great number of cultures have labored to take the outside part of grains away. Believe it or not, why do the French not eat whole grain croissants? Why do the Italians not eat whole grain pasta? Why do 4 billion people in the world who eat rice eat white rice and throw the brown away? People have, and it's a lot of work to take the hull off. Even interesting corn. Traditionally, corn was soaked in lye or lime to remove the hull, and it became hominy. And then that flour was ground up to make masa flour. And it's fascinating that there are really nasty plant defense proteins in the hull of virtually all grains, except sorghum and millet, which doesn't have a hull. And that's been a lot of what's made me infamous or famous. But cultures have always tried to get this hull off. Even cultures that don't take the hull off. The Incas did not de-hull quinoa, but the Incas fermented their quinoa. And the quinoa fermentation, interestingly enough, breaks down lectins. Bean soaking, all cultures that use beans soak their beans. And it turns out that beans have bacteria on the surface of the bean that during soaking ferments the lectins on the surface of the bean. And that's all that foam that you see coming out in a pot of beans when you're soaking them. That is the fermentation of those beans. And unfortunately, the champions of beans and grains don't bother to tell anybody that cultures have always figured out a way of detoxifying these plant compounds before they eat them. And it's to our detriment that we don't, keep those cultural traditions alive, getting back to what you and I just started about.
Yeah, it's really interesting. And for me, as I hear that, I think about the importance of taking this wider, more nuanced perspective on health. So, for example, if you look at something just through the lens of blood sugar, right? How much is this food going to elevate my blood sugar? You may well go, well, actually, instead of white rice, I'm going to have brown rice, right? Even though it doesn't always transpire that way, some studies have shown. But you may go down that route. But a lot of people struggle with digestion with brown rice. They don't feel good afterwards. They don't like the taste often of it. And certainly for me, my parents are Indian. I'm in an Indian family. I'm Indian by heritage and backgrounds. White rice is a big part of the diet I grew up eating. And what wearing a CGM, a continuous glucose monitor, has taught me, one of the things it's taught me is that I can still eat white rice, but I don't need to have a big bowl of it, a big plate of it, just a little bit. And I can enjoy it. It can be a nice accompaniment with something else I'm eating. And my blood sugar is relatively stable. So I've learned about quantity being quite important. But if you just look at it through the lens of blood sugar, you may say, no, you can't have these things. So I think that's really interesting. So getting back to that original point, Stephen, if you don't mind expanding. So 28 years ago, when you made those changes, were you bringing in whole grains then as well? What were you doing? And then how would that change now based upon the new things that you've learned?
So, no, I actually took whole grains out of my diet. And it's funny, my first book was called Dr. Gundry's Diet Evolution, and it came out in 2006. And my editor at the time, I had totally gotten rid of whole grains. It was kind of an Atkins with a lot of leaves diet, I guess you could say. And
so meat and fish in it as well at the time.
Yes.
Yeah.
Correct. And so that was kind of phase one of diets. When you're writing diet books, editors love phases. It's just something they do. And so phase two, once you got things under control, we introduced healthy whole grains and soy. And, I argued with her. I said, no, this has no place in it. She said, you don't understand nutrition books. the party line is, you have to reintroduce, whole grains because everybody knows that whole grains are, really important. I said, yeah, but you're missing the point. No, these are bad for you. And she said, you don't understand. You signed the contract. We own your book. And if you don't want to go with this, then, have a nice day and goodbye. And you don't get to publish the book. No, really? And they said, yeah, really. So that's in that book. And so the second time around, when the Plant Paradox came out, HarperCollins bought the book. And I said, look, there's going to be things in here that you guys are not going to like that goes against conventional wisdom. And I'm sorry, but it's non-negotiable. And they said, oh, no, we love this stuff. This is crazy. And it's controversial. And it was and is. But so, yeah, we got rid of all these things initially.
Yeah, really interesting. So I want to get to the controversy about that book because I think it's really interesting to sort of unpick what was controversial and actually what your view is on that today. Before we do that, though, just to finish off whole grains, you mentioned that you've been studying the blue zones a lot. There is a view that actually in some of these more traditional cultures, let's say the blue zones, that they will eat whole grains or they'll have breads with their meals and they'll have, traditionally made breads that maybe are fermenting 12, 16 hours, quite low gluten containing by the time that we eat them, as opposed to a lot of the breads in the UK and certainly in America, which are very, very quick turnover. Is it true? Do these guys have whole grains in their diets? And how does that then fit with what you just said about whole grains?
Yeah, and I've alluded to this in other books, but I go deep into it in the next book. What's fascinating about the blue zones, and I've spoken with Dan Butner, and he's a nice guy, and Paul Simon and Art Garfunkel had a verse: "A man hears what he wants to hear and disregards the rest." And when you look through the eyes of someone who is primarily a vegetarian, and you are looking for places to back up your view, then you don't see the other parts. So now I say this because I'm sorry, the only nutritionist who spent most of his life, career, in one of the blue zones, Loma Linda, California, the only blue zone in the United States. And just so we're clear, blue zones have nothing to do with ocean or anything like that. Blue zones actually refer to the fact that there was a meeting in Montpellier, France, where, and I won't mention the doctor's name, who was actually had no interest in nutrition and longevity back. He got out a map and he took a blue felt tip marker and he circled places that he thought had exceptional longevity. And it was the blue felt tip marker that was actually where the word blue zones came from. So since that time, let's take a couple of examples that I use in the book. Sardinia. So Sardinia is, quote, a blue zone, and not so fast. There are two major areas in Sardinia, people who live down by the water, the coast, and people who live in the mountainous region. There's very good papers that I allude to, cite that only the people up in the mountains have extended longevity. The people who live down by the water don't. The people who live down by the water, primarily fish eaters. The people who live up in the mountains are sheep herders. And fascinatingly, only the men in the mountainous region have the exceptional longevity. The women don't. They have no different longevity than any place else in Italy. And it's the men who have the longevity. And 85% of the men smoke, only 25% of the women smoke. And we can have fun with that all you want. The Nagoyan Peninsula in Costa Rica. Yes, lots of people eat corn and beans. There's a wonderful paper that I cite showing that the corn and beans are a negative aspect of that diet that's compensated for by the fact that these people in this peninsula are sheep herders, and they eat a lot of sheep yogurt and sheep cheeses. And so it's actually, so far, 2 of the blue zones are sheep herders. The Crete, Kari are sheep herders. They eat a lot of sheep yogurt and cheeses. They also have a fascinating plant called purslane, and everybody has actually seen purslane. It's a weed that is in every sidewalk crack wherever I've lived in the world. It's a pretty flower called moss rose or portulaca. But purslane is loaded with a short chain omega-3 fat called alpha-linolenic acid, ALA. And it was the basis of this purslane that the famous Lyon heart diet trial was founded. Anyhow, so now we got 3 of the 5 blue zones that are sheep herders. Oh, by the way, all the men smoke dramatically. At Chiaroli, south of Naples, that I visited, more centenarians than any place in the world. The men are big-time smokers. They're sheep and goat herders. And they eat a ton of rosemary, but we can get into that when you want to. Loma Linda. One of the things that shocked me when I was recruited to come to Loma Linda is their diet is 50% fat, primarily dairy fat. Yogurts, cheeses, butters. They also use a ton of mayonnaise. And I used to argue with the dietitians that they were killing my patients with this high-fat diet. And they go, excuse me, we're some of the longest living people in the world. Go away. We know what we're doing. And I go, but this, you're killing my patients. True. That's a true story. So tons of dairy in these blue zones. Now, the final blue zone, Okinawa. The Okinawans are unique in that they can't grow rice in Okinawa. And back in the 1600s, they luckily were able to import a purple sweet potato from China that actually thrived in Okinawa. And 85% of their diet is a purple sweet potato. They don't eat beans. They ferment their soy. They use natto and miso, but they don't eat soy. They don't eat tofu. And rice is just a tiny, tiny fraction of their diet. Now, the other thing that's unique about the Okinawans, in the rest of Japan, they are called the spice eaters, because the Okinawan diet has a huge amount of incredibly spicy, bitter vegetables, greens that they use and nobody else in, Japan uses. So they're nicknamed the spice eaters. So I'm sorry. If we're going to be honest, we should call the blue zones white zones.
Yeah. You've thrown a lot up there with your analysis of these blue zones. I love the section on dairy in your last book because you really highlighted how beneficial certain types of sheep's and goat's dairy, particularly fermented cheeses or fermented kefir, can be for our health. There's a general point there for me, Dr. Gundry, though, which is, and I guess this is a point we're touching on throughout this conversation. I guess it's something I'm very passionate about, that we love to take things in isolation. The media do, even, humans do, to simplify. What is it? Is it the beans or is it something else? Is it the meat or is it the vegetables? And I just think that any individual who I see in clinic, I'm always trying to assess the totality of their life and their lifestyle. So, for example, you're mentioning how some of these long-living men in some of these blue zones or white zones, whatever you want to call them, are smoking. It's interesting, isn't it, that there can be these populations who are smoking, yet they are living to a ripe old age in seemingly very good health. And certainly the way I look at it, and I'm interested in your perspective, Dr. Gundry, is that we all do things in our life. Some are health promoting, some are not health promoting, right? And we all make choices. And, you know, some of the negative things will negate some of the positive things, but it's about balance, isn't it? Overall, what are your health behaviors pointing to? Right, so alcohol, for example, yes, we can call alcohol a mitochondrial toxin. We can look at it in a reductionist way and say there are no benefits to drinking alcohol, for argument's sake, right? But then we can also look at some long-living populations and go, yeah, but they're seemingly they're living low-stress lifestyles, and they're having, you know, maybe half a glass of red wine in community most evenings. So therefore, I come down to think, well, in that setting, with active lives, with low levels of stress, when they're well slept, when they're generally having minimally processed foods, local in season, you know, they're doing a lot of good stuff. So maybe something that many people would call a mitochondrial toxin, alcohol, maybe in that context, it's not actually causing that many problems. Whereas if you're living, let's say, in a Western city, and you're sat down at a desk all day and you're hyper stressed and you don't have any friends or parents or family nearby, you have no sense of community, and you're drinking wine to help you de-stress from your life, maybe it's going to have a different effect on the body in that context. So yeah, I wonder if I could have your perspective on what I've just said. To make sure you're taking action after watching this video, I've created a free guide to help you build healthy habits. We can all make short-term change, but can those changes become a fundamental part of our life? Often they don't. And that's why in this free guide, I share with you the 6 crucial steps you need to take. They're really, really effective. If you want to get hold of that free guide right now, all you have to do is click the link in the description box below.
Yeah, you're absolutely right. I mean, for instance, the Catawans, who Stefan Lundeberg spent his career studying this island community in Papua New Guinea, the Kitavans are big-time smokers, and they have zero coronary artery disease. There's no stroke, and they have virtually no cancer. And you go, but, you know, they're smokers. And you look at these other communities and they're smokers. Now, let me put on my heart surgeon hat for a minute. Back before our insulin resistance, diabetes heyday, the vast majority of people that I operated on for coronary artery disease were smokers. Now, in a way, it was great, because these smokers were skinny, bless their hearts, and their blockages in their coronary arteries were very distinct. They were at the proximal part of blood vessels, actually wherever a bend was. And once we got past that blockage, quite frankly, the rest of their blood vessels were pristine. They were gorgeous. There was no plaque. There was no calcification. It was heaven on earth for heart surgeons. Skinny patient. Once you jump past this blockage, sewing was a piece of cake. Then along came normal patients now who have insulin resistance. They're overweight or obese. They have metabolic syndrome. These people, their coronary artery disease was diffuse. In other words, there's lump after lump after lump after lump. When we would operate on these people, they literally would have inflammatory, almost scars on the top of their blood vessels that we would literally peel off just to get to the blood vessel. And the inside was just a bunch of mush. And I'm a transplant surgeon as well. And so when we started doing heart transplants, people, despite excellent immunosuppression through the years, would get coronary artery disease in their blood vessels. But the coronary artery disease looked identical to someone with diabetes. All this mush all along. And that, to me, made me put two and two together and went, well, wait a minute. We know that the coronary artery disease in our transplants is because the immune system is attacking the foreign lining of this blood vessel. And we haven't done a perfect job of stopping the immune system from recognizing this as foreign. And it looks exactly like our metabolic syndrome diabetic patients. This is an inflammatory process attacking a blood vessel, which we started talking about. Now, what about the smokers? So the problem with smoking, and I talked about nicotine is really good for you. Now, don't splash the airways that I want everybody to smoke. That's not what I'm saying. Nicotine is one of the best mitochondrial uncouplers there is. In fact, there's a UK study that I've cited that you're probably aware of, looking at 60,000 physicians. And the physicians who smoked had half the incidence of Parkinson's and dementia than the physicians who didn't smoke. So there's something there, and it's nicotine. Now, the problem with nicotine, even though it's a great mitochondrial uncoupler, it's a great addictive substance, as any tobacco company person knows. So I'm not yelling for everybody to take up nicotine and don't chew nicotine gum and don't wear a nicotine patch. But why is it that these smokers did okay? Well, so nicotine smoking produces oxidative stress. And one of the things about oxidative stress, we deal with oxidative stress, animals deal with oxidative stress by producing vitamin C. We, unfortunately, don't have the final gene. We have a silence gene of the 5 sequence to take glucose and turn it into vitamin C. That final gene is silenced, so we can't make vitamin C. All animals make vitamin C except us and a few New World monkeys and guinea pigs. And all animals, when under stress, pour out vitamin C. Smoking, so bending blood vessels breaks collagen. Collagen is the rebar in our blood vessels. And as they bend, it breaks. And collagen sticks out into the bloodstream. And normally, vitamin C actually re-knits collagen. If all of your vitamin C is used up in smoking, then that exposed collagen invites scar tissue. And so, to me, that explains why these smokers, at bends in their arteries, major bends in their arteries, developed blockages, but everything else was crystal clear. And one of my friends who recently passed away, Bill Sardi, has done some beautiful experiments with rats who had that final gene sequence, and so they couldn't make vitamin C. And these rats lived only 50% as long as a normal rat. But when they put vitamin C back in their drinking water, then they lived the same life as a normal rat. So what about all these blue zones who are smokers? Well, they're just loaded with vitamin C containing foods in their diet. In fact, olive oil, a component of olive oil, a polyphenol called hydroxytyrosol, doubles vitamin C production in humans. And so you start going, well, son of a gun, these guys, have taken a potential vice and kind of negated the negative aspects of that vice and gotten the benefit, which is nicotine. And that, I think, explains quite a bit of how they get away with a potential terrible thing.
It's really fascinating to think about that. And again, I want to be clear, you're not promoting that people start taking up smoking. I'm certainly not.
No.
This is just so there's no doubt there at all. But it's interesting, isn't it? Why you can live to old age in good health and smoke. And yes, Is vitamin C part of the picture? Is low stress? Is their movement? The fact that they're sheep herders? What is it? And I guess maybe your next book will help tease that out for us. What are those factors? Because I actually don't believe it's one factor. I believe it's the multiple lifestyle, environmental inputs that person is getting over the course of their life that actually is telling us what's going to happen. And how many times do we hear about these people at 108 or 112? Like I think I read about a French lady the other day who has a whiskey and a cigarette every day. And again, we can't draw conclusions from that as to how all of us should be living. But it's nonetheless very interesting how so many people who live to old age in good health aren't thinking about living to old age in good health. It's just happening. And I do sometimes think about what does it say about Western culture that we, are so obsessed these days with anti-aging.
We have a joke in our clinics that 150 is the new 100. But you're right. And I warn all of, for instance, my female and even male patients who want to vigorously pursue hormone replacement therapy so that they have the hormone levels of a 20-year-old. All of these super old people, I got news for you. I've never been on hormone replacement. And, that as I tell my female patients, look, you were designed to make estrogen for one reason, and that's to have children. And I was designed not to make much estrogen because I wasn't designed to have children. And once your eggs reach a certain point where they're probably not a good idea to pop out, your estrogen should fall so you don't pop your eggs out, and you're done. And the idea that estrogen, don't get me wrong, estrogen therapy started at the right time may be beneficial, but we don't need to go down that line. But most of these super old agers, they've never been on hormone replacement.
A couple of things that have come up in this conversation so far: lectins and the term mitochondrial uncoupling. Now, when I read Unlocking the Keto Code, that was the first time I'd come across this concept of mitochondrial uncoupling. And again, my summary, and again, please feel free to correct this if you see this differently. But really what that book showed me, and what that book was trying to teach, I think, was that the benefits, the supposed benefits that many people are reporting on ketogenic diets is not coming from the ketones. Rather, it's coming from the fact that the mitochondria are being uncoupled. And you outline in that book that actually you don't necessarily need to follow a ketogenic diet to get the benefits of mitochondrial uncoupling. And in that book, you outlined all kinds of things that we can do that may give us some of those benefits, including intermittent fasting, increasing polyphenols, increasing fiber, polyamines, cold therapy, fermented foods. Is that a accurate-ish summary of the kind of main argument you were trying to put forward in that book?
Correct. One of the papers, when I was researching the energy paradox, there's a PhD researcher, Dr. Brand, who in 2000 wrote a fairly small paper called Uncoupling to Survive. And in it, he makes the argument that if we're starving to death, we would want to save our mitochondria at all costs, because if mitochondria die, then who cares if, well, number one, you're not going to survive, but since mitochondria make ATP for us, we've got to keep them alive. And what he proposed was, if you're starving, you're making a lot of ketones. It's one of the only ways to make ketones. Take free fatty acids out of fat cells, put them into the liver and make ketones. And ketones are useful because they're small enough that they can get through the blood-brain barrier. Free fatty acids can't fast enough. And they can be used as a fuel to keep neurons alive until you finally find some glucose. But ketones are actually a signaling molecule that basically say, hey, times are tough. There's no food. That's the only reason you're making ketones or you're exercising like Peter or Atia. That's the only two ways you're going to do it. And you mitochondria are under threat. And so protect your cells by doing two things. Number one, stop trying to make ATP aggressively, because making ATP damages mitochondria. And number two, make more of your cells so that each one of you individually will not have to carry a big workload. And in the new book, and I do it on podcasts, the example I use is, let's suppose we have a dog sled and we have one dog pulling the sled. Well, the dog can pull the sled. You won't go very fast and you won't go very far before the dog gets tired and you have to stop. Now, if we hook up 5 more dogs to the same dog sled, now each dog has to do 1/6 of the work. You'll go a lot faster and you'll go a lot farther. The consequence, though, is you now have to feed 6 dogs rather than 1 dog. And so what happens when you make each mitochondria work less by what's called uncoupling, and it's a real thing, it was discovered many, many years ago, and add more mitochondria to share the workload, then the downside of that is they waste fuel, if you will, and you actually lose weight. And so the actual consequence of a ketogenic diet is that you actually waste fuel. And you waste fuel on purpose so that you don't damage the energy factories, mitochondria. And that's actually one of the main reasons why uncoupling exists in the first place. The other interesting thing about uncoupling is our 30% of all the fuel we absorb is wasted through uncoupled mitochondria. And that waste is actually thermogenic. When mitochondria uncouple, you generate heat. And so we actually generate heat by mitochondrial uncoupling. And what's interesting is brown fat, and the reason brown fat is brown is because of it's dense with mitochondria. Brown fat is thermogenic because these mitochondria uncouple. And so not only will ketones uncouple mitochondria, but there's all other tricks that, son of a gun, long-lived people have learned, long-lived societies have learned, and that's polyphenol-containing foods, intermittent fasting. I joke with all my patients, you really think our ancestors crawled out of the cave and said, what's for breakfast? There was no breakfast. We had no storage system. There were no cupboards. There were no refrigerators. We had to find breakfast. Subsequently, we learned how to preserve foods, and that actually gets into we preserved foods the only way we could, and that was fermentation.
Yeah. It's absolutely fascinating because when I think about health, when I think about diets and lifestyles, I'm always trying to think about what's the unifying philosophy? What's the unifying components? Why is it that some of my patients can go whole food plant-based and seemingly thrive, whereas others go low carbohydrate whole food based and are also thriving? And I've always felt that these dietary wars are a little bit problematic because from clinical practice, I've seen people do seemingly quite different things and still do well. So what is the unifying feature? Okay, well, all the diets that work well in the short term and long term, I think help lower inflammation, right? That I think pulls them all together. all diets that tend to do well in the short term and long term, I think help us be metabolically flexible. And I know you've written about metabolic flexibility. We have time. We'll talk about it today. But then I thought I'd never thought about mitochondrial uncoupling until your work with Unlocking the Keto Code, where I thought, wow, if this is true, this is another unifying concept that shows why potentially some quite different diets and lifestyles still can harness and encourage really good health outcomes. Now, since that has come out, Dr. Gundry, has there been any pushback? Like, is mitochondrial uncoupling well accepted science, or is it still a hypothesis that you're trying to put forward?
No, it's not my hypothesis. Mitochondrial uncoupling is very well proven science. We know there are 5 mitochondrial uncoupling proteins, UPCs, that were actually discovered in the 1970s. And these uncoupling proteins actually are emergency exits out of the electron transport chain. And in the book, I use the example of the Mito Club, where things can get, it's the hottest club in town, and things can get pretty rowdy, and people are trying to couple when they go to these clubs. And unfortunately, things can get so rowdy that you've got to disperse the heat and the energy. And it's actually what happens is, protons are supposed to couple with oxygen and exit through a one-way turnstile and generate ATP. And that process of the electron transport chain is really nasty, generating reactive oxygen species. And so you need to have literally pop-offs, like a pressure cooker. If a pressure cooker gets too high, you've got to release that pressure. So you have a pop-off valve. And what was discovered is that mitochondria have these pop-off valves, and these uncoupling proteins, these emergency exits, are manipulable. They are controllable by chemical signals, by, for instance, ketones uncouple mitochondria. They open these trapdoors. Polyphenols open these trapdoors. And my favorite example, which I talk about a lot, is this compound that was discovered after World War II called 2,4-dinitrophenol, DNP. And it's a fascinating story. Munition workers in France and Germany during World War I were noted to be profoundly skinny. And they were always running a temperature, and they were eating incessantly, but they were profoundly skinny. And it wasn't until after the 1920s when it was discovered that in the process of manufacturing gunpowder, there's a chemical called 2,4-dinitrophenol. Remember that word phenol. It will show up in polyphenols. And a couple of Stanford doctors said, hey, these guys were really skinny, and obviously this stuff makes you really skinny, and I think it's a weight loss drug. So they actually wrote over 100,000 prescriptions for 2,4-DNP to humans. Mm-hmm. And it was miraculous. At a normal dose, you would lose a pound a week. If you up the dose, you could lose up to 5 pounds per week. And it was a miracle, except the more you took, the higher your temperature went. You actually developed cataracts, and to the extreme, you died. Now, subsequently, when the FDA banned DNP in 1938, but subsequently it was discovered that DNP was the first discovered oral mitochondrial uncoupler. And that explains why they lost so much weight. And it also explains why they ran such high temperatures, because they were generating heat. Now, there's been a lot of interest in looking at precursors of DNP to see if you could control the side effects. And there's several companies that are really looking into this. But the long story short is we know from actual fact that phenols uncouple mitochondria. And so you go then, well, gosh, let's look at the spice trade. Let's look at polyphenol consuming populations. And you go, son of a gun. These things, were the original drugs. And that's why people paid. Nobody paid a lot of money to put black pepper on their steak. They paid a lot of money to get the uncoupling benefit of black pepper.
Yeah, it's so interesting to look at food through that lens. Of course, people can read the book and get all the detail on all the things that you recommend. We touched on intermittent fasting. There's a section on that. Fiber, as I said, prebiotics, postbiotics, polyphenols you mentioned. Just a quick summary of foods containing polyphenols for people.
Well, the fun thing, let me go back. So plants have mitochondria that are called chloroplasts. And plants use photons, which is equivalent to our oxygen. And photons from sunlight are extremely damaging to plant mitochondria, just like oxygen is actually extremely damaging to our mitochondria. But it can't live with it, can't live without it. So plants manufacture polyphenols in their leaves or in their fruit to protect the mitochondria from damage from sunlight and to repair that sunlight. And they actually uncouple chloroplasts. So now when we eat polyphenols, and best in the fall, we get to see all the polyphenols in the leaves of trees that we didn't see because they were covered up by the green. And as that green chlorophyll goes away, there's the polyphenols, all the yellows, oranges, reds, purples, all these magnificent colors. Those are the polyphenols. The problem with polyphenols are we absorb them incredibly poorly. But some of the exciting new evidence is that polyphenols are one of the favorite foods of our gut microbiome. Our microbiome just thinks polyphenols is sliced bread, and that's a poor analogy. But so they, in turn, make polyphenols absorbable, bioavailable. And so the benefit, so whenever you see a beautiful colored something, that's the polyphenols. And for instance, olive oils loaded with polyphenols, cacao, dark chocolate loaded with polyphenols, coffee loaded with polyphenols, tea loaded with polyphenols, and so on and so forth. Red wine has its benefit because not only the polyphenols in the grape skins and the seeds, but also great amount of red wine is aged in oak wood barrels, and wood has polyphenols that are absorbed.
Yeah, thank you. In the context then of mitochondrial uncoupling, why is it that you're so passionate about recommending sheep and goats products? So
these blue zones are sheep herders, goat herders. And sheep and goats, first of all, a lot of people now have heard of medium chain triglycerides, MCT oil. And medium chain triglycerides are a fat that's unique in that they are absorbed directly through the wall of our gut rather than on chylomicrons, and that's a long story, but they go directly into our liver. And they're converted, for the most part, into ketones, regardless of what you're eating. Mm-hmm. So you could have a fresh fruit salad and have a tablespoon of MCT oil, and you will generate ketones despite eating a very high carbohydrate load, which is interesting. So it turns out that all of the various medium chain triglycerides are named after goat, capra. So there's caprylic acid, caprolic acid, capra, goat. Why? Because it turns out that goat and sheep, 30% of all the fat in goat and sheep milk are medium chain triglycerides. Cows don't really make a lot of medium chain triglycerides. Humans make a lot of medium chain triglycerides in our milk. Water buffalo have a lot of medium chain triglycerides. Turns out donkey milk actually has a lot of medium chain triglycerides. So isn't it interesting that these super long-lived blue zone, white zone people are sheep and goat herders, and that a lot of their diet is sheep yogurts and goat yogurts and kefirs and cheeses. And part of what I propose is these guys live a long time because they're uncoupling their mitochondria. Now, there's another fascinating globule in whole milk, regardless of the animal. That's a milk fat globule membrane. And it's a membrane that actually in animal milk surrounds the fat globules. It's only in fat. It's not in skim milk. That's removed. And it, in and of itself, and there's good papers, is a mitochondrial uncoupler. So isn't it interesting, for instance, getting back to that one paper, butter has a negative effect on angina. Butter doesn't have any of these, whereas cheese has these things. In fact, I'll give you a little heads up. Harvard researchers have determined, one assistant professor has determined that whole fat ice cream eating actually reduces the risk of diabetes. And that certainly goes against party line and conventional wisdom. Yet every which way you break it down, the same thing comes up. And it's actually because of the fat globule membranes in whole fat milks, and they're in cheeses.
Yeah, well, if we had more time, I'd love to explore that, because I'm certainly not recommending whole fat ice cream to my patients.
No, I'm not recommending that everybody have ice cream for diabetes.
I mean, in terms of what we have got general agreement on so far, fermented foods is something that's very good for us. Polyphenols, however we might get them, dark chocolate, tea, coffee, colorful vegetables, whatever it might be, good for us. Olive oil, really, really good for us for a variety of different reasons. You're making the case for goat's cheese and sheep's cheese and why specifically they may be beneficial for us. In terms of a food that you have become globally associated with, for potentially recommending that some of us, all of us, avoid, is lectins. Now, lectins are in a lot of different foods. As you said, you published The Plant Paradox 6 years ago. It blew up globally. It was controversial. How do you see the lectin situation now? What's your current view? Has it evolved? And also, the question I really want to understand from you is, do you recommend that everybody thinks about avoiding lectins, or is it more so for people who've got impaired gut microbiomes and potentially severe autoimmune disease, where you may see more of that benefit?
So about 80% of my practice now is autoimmune diseases. A lot of them have been kind of all over the United States, the world, looking for somebody to fix it. And they kind of end up in my office. Every human, and I measure leaky gut tests on these people, on a lot of my patients. And every human being so far with an autoimmune disease has leaky gut, 100%. 99.5% of people with leaky gut have antibodies to wheat germ agglutinin, the various gluten molecules, and non-wheat proteins, as well as 70% of them have antibodies to corn. They cross-react with a gluten-like molecule in oats, barley, rye have gluten. And so I can say unequivocally that the vast majority of people, number one, have leaky gut for reasons I've gone into before, but they have antibodies against numerous lectin-containing foods. We also test them against antibodies to various lectins. And most people carry antibodies to one or more beans. A great number of people carry antibodies to the lectins in cucumbers, to tomatoes, to potatoes, to peppers. Interestingly, in the new book, I write about a new class of lectins that I did not want to go into in the plant paradox because I didn't want to be even more controversial. But there's a class of lectins called aquaporins, and we'll leave it at that. But spinach has an aquaporin. And some of my MS patients are big-time spinach eaters, and they carry an antibody to the spinach aquaporin. And when we take spinach away from them, that was the final thing that flipped things around. Now, having said all that, the exciting thing, the reason I do this, is if we follow these people 9 months to a year, and I published this, these people, their antibodies against all of these components subside, disappear. They are gone. 100% of them lose these antibodies. And I've had people who have been gluten-free for 10 years still have antibodies to wheat germ agglutinin and gluten. When we take away the other lectin-containing foods from them, then they lose all these antibodies. And we can reintroduce these foods because we've sealed, and they're leaky gut seals. And I guess that's the point. And one of the things that I've tried to make people understand is that cultures of fermented foods have taken hulls off of grains from the beginning of agriculture because fermentation reduces lectins. And so does taking the hull off of things. And these people didn't know that that's why they were doing it, but they absolutely felt better.
Yeah, I really appreciate that. And you know, maybe I can persuade you to have a part 2 one day where we actually explore that a bit more, because I think it's a really, really interesting point. Again, it speaks to this theme throughout our conversation that context matters, what's going on with you at this current time. And, you know, Dr. Fasano's theory on autoimmune disease, which I really, really like, is that in order to have any autoimmune disease, you need 3 things: genetic susceptibility, some form of environmental stressor, whether it's food, pollution, stress, whatever it might be, and you need increased intestinal permeability, also known as leaky guts. If you've got those things and you have an active autoimmune disease, then it stands to reason that the diet you need at that point may be different from someone who's got an intact gut barrier, who doesn't have the genetics, who's actually feeling really good. So, you know, when we say, should someone avoid gluten or not avoid gluten? Well, it kind of depends. Just to sort of close off the loop there for this conversation, at least, I know you're in clinic. I want to be respectful to your time. I think we can say for some people that having a more restrictive diet, maybe, not having lectins for a period of time whilst other things are being done to repair their body and their gut barrier, you know, that could be a helpful scenario, basically. And you wouldn't necessarily say that everyone out there has to now stop eating lectins.
No, but one thing that I think is very important for people to realize, and I've written about it before, but I'm going into it even more. America is awash with glyphosate, Roundup. It's in all of our food. It's been sprayed on all of our grain crops, not as a GMO product, but to desiccate them. And it's in our wine. It's everywhere. It's in our organic food. And one of the amazing things is, I have a number of patients with autoimmune disease that we put into remission, and they come over to France or they come over to Italy. I'll just use those as examples. And they go, oh my gosh, a croissant, I'm going to have a croissant, or a baguette, I'm going to have a baguette, or I'm going to have a pizza, or I'm going to have pasta. And they do great. They do not react. They do not get bowel issues. And they come back and say, oh, Dr. Gundry's cured me. I can have these foods again. And then they start eating our American version of this. And they eat our American bread, our American pizzas or whatever. And within a couple of weeks, they flare. And they go, what the heck? And one of the things that I've really become convinced on is that you, luckily, have far less glyphosate in your foods. And in certain countries, it's banned now. And glyphosate will absolutely cause leaky gut without any other.
Yeah. I'm glad you raised that point. There's so many threads there that I want to continue talking about. Maybe if we have a part 2, we can actually explore some of those at some point in the future. Just to finish off, Dr. Gundry, I really appreciate your commitment to sharing the knowledge that you're learning with people all over the world to try and help them improve their health. I appreciate the fact that you have openly acknowledged where you might have got things wrong in the past and where you actually have evolved your view. I think that's a really wonderful thing for us to see and for us all to try and practice in our own lives. Just to finish off then, could you just summarize to people who have felt inspired by this conversation, inspired by your work, say, okay, Dr. Gundry, that's it. I'm sick of being tired. All right, I'm sick of not having energy to do the things that I want. I want to get on top of my health. What are your top tips for me? What food should I start to include? What should I avoid? What can I do right now? I wonder if you have any closing comments to help people.
Some of my most difficult patients, I actually ask them to become a gorilla who lives in Italy. And by that, I mean, I want you to eat a lot of leaves and pour olive oil on it. And if you do that, you'll cover almost all the bases that you need for good health. My wife and I are primarily what we call veg aquarians. And by that, I mean, we do eat a lot of leaves and vegetables. And on the weekends, we usually have wild shellfish like clams, oysters, mussels, shrimp. And there's, I think, a lot of reasons to do that.
And what about fruit? You mentioned that 28 years ago, when you made all these changes, you completely eliminated fruit.
We carry a genetic mutation like great apes that allow us to take fructose in fruit and virtually instantaneously convert it into fat to store fat for the winter. And there are literal huge books looking at great apes only gain weight during fruit season, and fruit season lasts a finite period of time, even in the jungle. And fruit has been unfortunately engineered, hybridized for sugar content, for fructose content. And one of my favorite sayings, and I'll repeat it here today, give fruit the boot if you want to improve your health. If you really want fruit, get yourself a juicer, juice the fruit, throw the juice away and take the pulp and mix it in goat or sheep yogurt. And that's where all the polyphenols are, and you'll do yourself a favor.
Oh, that's going to be right at the end. There's so many threads that I want to dive deeper into. But again, we'll say that for part 2. If people are new to your work and they go, look, Dr. Gundry, you've published so many books. Where do I start? Which book would you currently point them towards?
Well, Unlocking the Keto Code actually summarizes everything in the past with my new thoughts. The new book will drop January 4th of 2024. I can't tell you the name yet. I know it, but I can't tell you. But go to my YouTube channels. I have 2 YouTube channels. Come to Instagram, Dr. Steven Gundry. You can come to my website, drgundry.com. You can come to gundrymd.com, my supplement and food company. Yeah, in fact, I just got a wonderful email from a woman 2 days ago that I popped up on a podcast and she started watching it. And she said, I was skeptical, but her health was so awful. She said, I started putting into place things you recommended. And she said, now 60 days later, she said, I couldn't even leave my house. Now my life has turned around. I'm active. I no longer have bowel issues. And now I can help my son who suffers from PTSD, and my anxiety's gone. And now I'm going to help him just from watching a YouTube video that captivated her.
If you enjoyed that conversation about the foods to bring into our diet, I think you are really going to enjoy this one about the foods to consider taking out.
We need to realize whatever we put into our body is either going to take our health down or build our health back up. And it all works at the level of the defense systems.